Hello, everybody. This is Abnormal Psychology, and this is part two of post traumatic stress disorder. If we look at various populations and the rates at which they have PTSD, we see that in police, uh, particularly metro police as opposed to suburban police, firefighters, first responders of all kinds, military veterans have a much higher than prevalence than the average population, or the normal population. People who have experienced assaults, including battered women and abused children, the rates be somewhere between 35 and 50%. What goes with this? Well, alcoholism is very common, very, very common. Up to 75% of Vietnam veterans have alcohol abuse syndromes. Depression, up to 75% of firefighters with PTSD also have depression. I can't actually imagine how it's possible to have PTSD without depression, but of course that happens. And then people have traumatic brain injuries, particularly those who are also combat soldiers. Whoa, that raises it. But anybody with a traumatic brain injury can develop post-traumatic uh, stress disorder. And the prevalence of comorbid anxiety disorders is fairly common. So panic disorder, for example. Now, what causes PTSD? Well, there are a lot of ways to look at this, and we're not entirely sure what causes it. Surely there's a genetic vulnerability, but what else is involved? Well, we know that whatever causes a dysregulation in the biological responses to trauma, whether that's a genetic base or whether it's a developed biological base, we know that there's an arousal system problem. So the amygdala is involved, and the amygdala has something to do with generating the fight or flight response and in storing memories that have a particularly high emotional component, and particularly those that are associated with danger, because nature wants us to protect ourselves and be able to recall things easily that were dangerous or that we believed were dangerous to protect us. And somehow that mechanism has gone awry. In fact, that mechanism, which ought to not create an increase in the arousal over time, actually does just that. There is an increase in the arousal and the symptoms surrounding that arousal in people with post-traumatic stress disorder. So those memories become strengthened strangely over time. So there is something involved in a neurophysiology of encoding memories that has gone awry. So what are we really looking at here? We're really looking at a breakdown of the normal stress response where repeated adrenaline spikes, which occur over time for some reason, progressively sensitizes the brain chemistry, which provokes even greater floods of adrenaline at lower thresholds. Okay? That's the current thinking. Now, of course, there are old. I don't really want to go into the old thinking of the psychoanalytic explanations. It's convoluted. It's typical reasoning, and I don't want to go through that. I'm choosing not to. Okay, we know that behaviorists say, well, we learn to respond to stimuli associated with that event, that are cues to that event, but not everybody who's experiences or exposed to a trauma or scene of devastation or violence develops PTSD, and different traumatic events are more or less likely to lead to PTSD. So classical conditioning can't be the only explanation for the development of PTSD. There are cognitive appraisal explanations. It's got to be a component. It's a sequelae. There are sequelae that are cognitive associated with the development of PTSD. How do we treat this? Good question. Treatment is not something that the majority of people get. And the treatment is very spotty, in addition to being inadequate in many ways. And it varies quite a bit. So if we have someone who has subsequent depression or comorbid depression, even before or after the development of PTSD, and if they have anxiety, which of course is part of the picture, then SSRIs, selective serotonin reuptake inhibitors, are often the first line of medication that you would use. There are safe ones that have very low potential for abuse, misuse, and they tend to work well for both the anxiety and the depression. We don't generally want to give benzodiazepines like Xanax for anxiety unless it's overwhelming them, because it's easy to abuse. For treatment-resistant cases of PTSD, we might think about antipsychotics, partly because they are very sedating. And we want to eventually use a cognitive behavior approach, where there is eventually some form of exposure, either using virtual reality, which is commonly used for lots of different things, especially for combat soldiers, but not for people who have been assaulted personally or sexually abused. That's not appropriate. I don't imagine, but my thinking there is not the result of investigating that intensely. I have been informed that that's not something that we currently do. And I can only imagine how it might be done, but I suspect at this point we're not doing that. And there are other forms of treatment, EMDR, eye movement desensitization and reprocessing. Most people think the jury's still out on that, but for some people it appears to work well. I have an idea about why, but I don't want to speculate about that in this particular video. So one of the ways that can work well is ongoing what's called imaginal exposure. So you're actually recounting the specifics of the disturbing memories over and over again in therapy with a therapist who's trained in how to do this. And they are also working with you on the cognitive distortions that you have that are involved in the appraisal that you make when you recount the traumas. This seems to work over a period of months. But of course, many people don't want to talk about, they don't want to revisit the trauma that they've had. It's hard to have them see why that would work. But what it does is it desensitizes you, okay? So you have a fear structure that is involved with stimuli and responses. And so you access the fear memory, which allows for a change in the fear structure, which is essentially desensitizing you to the memory. Something you will never forget, but which doesn't increase your response over time to that and diminishes the response. So you get the change as a result of what we call cognitive reframing. You habituate to the memory by retelling it in this imaginal exposure. You get to reappraise it, and you develop a mastery over that. Okay? Now, there are some patients who literally cannot engage in these memories for one reason or another. They cannot visually come up with a visitation of the trauma. They may not be able to emotionally engage for one reason or another. And there is a risk of flooding and flashbacks. I mean, one of the things you would do early on is what you would do in treating any anxiety disorder, which is, and this is not one of those anymore, but anxiety is a part of this disorder. So what you do is you would treat them how to use and effectively the relaxation kinds of things that you would teach them and they get really good at before they go through the imaginal exposure. That would be a part of the mastery system that you would use to help them feel like they have some control over their responses, okay? The clinical use of virtual reality has become very sophisticated with vibration platforms, heat sources with an infrared lamp, nasal puffers with smells that might be a part of the triggering stimuli that the person has, and the visual imagery has become more and more sophisticated using the goggles. So that's a look at PTSD. That's part 2. I hope this has been useful. Please consider liking or unliking or disliking the video and subscribing. That'll help you know when new videos come up. Thank you.